up to the waterfall this morning, and I went with a local guide. This is before this. She was sure-footed goat mountain climber. She was going up that thing like there was no tomorrow, and I'm like behind her going, oh my God, I don't think I can keep up. Oh my goodness. Just thought I'd end the day with a little bit of a light presentation. A lot different probably to what you're all used to, because I know I'm filled with a room full of ED physicians, paramedics and ED nurses. Just how to prepare patients from a different perspective today, if that's okay. Who is this person on the stage? Just a bit of background about myself. I've had 24 years as a perioperative RN, 14 years in the public hospital setting, 9 years in private hospital, of which had an ED department as well. I was ortho trained, but the last 9 years mainly in plastics. I worked majority of my shifts in public after hours, which meant I had to know all the specialties, and as you can imagine, a lot of trauma. I'm accredited surgical assistant in multiple hospitals. I work in Victoria. And I was endorsed as an MP 2 years ago, did my Masters of Nursing, nurse practitioner. I currently own and operate my own telehealth clinic, which is primary care. Again, I also get a lot of trauma patients ringing through my service because it is a purely bulk billed service for patients. So I do get a lot of patients remotely, rural, and there are traumas that come through there as well. Outcomes for trauma patients. When we're discussing trauma patients, there's usually the steps that patients go through. And the outcomes are generally either treatment and discharge from ED or admission to hospital for IV antis, dressings, or even further investigations. But the big one is some patients need to go to surgery. And this is where I live, this is my love, and this is sometimes where they end up. Why do emergency healthcare workers need to know about the theatre environment? I think comprehensive workup is required for theatre. Medications and imaging can affect surgical planning and strategies. Appropriate patient history for surgical intervention. Smooth transition to the operating theatre is a massive one. And most critical reason, most optimal patient outcome. When I'm thinking about ED and patients in general, I think today my point was that we often see patients in our department and we compartmentalise them in our department. When I was a baby nurse going through uni, I went straight from high school, straight to Bachelor of Nursing. I had no life experience, and my lecturers kept banging on about continuity of care. Being a baby nurse, I thought that meant that if I was on a shift for the week, I would be, given the same patient for the week, and that was continuity of care. I now don't believe that. It is part of it, but continuity of care is looking after a patient from the time they present to a hospital until they leave. Continuity of care is not one department, it is all the departments working together to make sure that that patient's outcome is the best for them. What trauma cases result in surgery? I did do a little disclaimer down the bottom. These aren't all the cases, these are just some of them. All the specialties: orthopaedics, fractures, ruptured tendons or Achilles. Plastics can involve lacerations, hand injuries, which are fractures and soft tissue, abscess, burns, traumatic amputation, and all soft tissue injuries. You've got your general specialty: bowel obstruction, acute appendicitis, strangulated hernia, cholecystitis. Vascular, we're looking at things like AAAs, infection of vascular ulcers, necrotic diabetic wounds or toes, vascular insufficiency causing blood restriction, and you can have post-op complications present to ED as well. Thoracic and cardiac, you're looking at pulmonary embolisms, aneurysms, acute arrhythmias, and again, post-op complications. Obstetrics and gynae, you have your Caesars, miscarriage, ovarian cysts, and fibroids causing acute pain and bleeding. And you get your multi-traumas, and they're the big ones. And, you know, as we heard before, there's a very small window of opportunity for these patients to do well. MVAs or natural disasters, for example, and which often involves multidisciplinary teams in the operating theatre. Process for trauma patients to get to theatre. Patients, this is just a very basic rundown. Patients are first attended by the paramedics after calling 000. I think some of you have been in that position. Ambulance takes a trauma patient to emergency department. Side note, sometimes this is not, the paramedics in the ambulance are bypassed and the patients go straight to ED. Emergency department clinicians assess, diagnose with interventions such as pathology, imaging, ECG, etc. Diagnosis is confirmed and then referred to the specialty registrar and or consultant where appropriate. Booked for theatre. Critical post-op, peri-op workup requirements. I did make notes on this one that I'm going to actually read. So medications, that's the big one. Number one, anticoagulants. Aspirin is generally not ceased before the majority of elective surgeries. Eliquis, heparin, warfarin, Xarelto and clopidogrel, usually all ceased at least 3 days prior to elective surgeries. I'm talking about elective surgeries, not emergencies right now. Emergency trauma cases do not often have the luxury of ceasing blood thinners before surgery, but identifying if and what blood thinners the patient's taking allows the operating theatre team, particularly the anaesthetist, the ability to pre-plan for blood transfusions and expectations of higher blood loss. Another one that's come into effect very recently, another medication is Ozempic. I'm sure everyone's heard of that. I'm going to use the term Ozempic, but I am going to also say that this is there is other weight loss drugs that have the same mechanisms of action, such as Wegovy and Mounjaro. The semaglutide is a glucagonide-like peptide 1 receptor agonist. Ozempic was initially created for blood sugar management in diabetes patients, but now a significant percentage of the population uses Ozempic for weight loss management due to its effects of lowering appetite and slowing down the digestion in the stomach. Ozempic is generally ceased 4 weeks prior to elective surgeries. This is a bit of a point of contention between some anaesthetists. There's still discussion going on about that, due to the slowing of the digestion that it causes, therefore making fasting times variable. In emergency surgery, again, as with the blood thinners, obviously the patient is unable to cease the medication in advance and therefore placing the patients at a higher risk of aspiration during intubation and anaesthesia. So that's another really imperative piece of information that the theatre team need to know, particularly the anaesthetist, if they've been taking this, any of those medications, just mainly for airway obstruction, aspiration, and their pre-planning. Enough about medications. Imaging. X-rays, for example, fractures, ultrasounds for collections or masses, bloods, FBE, ECG. It's really important that pre-op patients have an informed consent and understanding of necessity of the surgery, not only for the patient, but for the families as well. There's people that sit next to them in those beds next to them in the emergency department. Individual patient special requirements. I added this just to be aware that in the operating theatre is a really scary place. I have had the privilege of being able to look after patients before, during and after surgery, and there is nothing that a patient likes than seeing a friendly face because it is a really scary environment. But individual requirements such as paediatric patients with dementia or cognitive disabilities, alcohol and recreational drug use, we need to keep those into consideration when prepping patients for theatre as well. Again, I'm not trying to tell you how to suck eggs. I know you all know how to do your job, but a comprehensive history flagging any of the issues that may compromise care in theatre. How comprehensive workup affects perioperative care and outcomes. A good peri-op workup will improve the pre-planning for anaesthetics, improve planning for surgical equipment. Misdiagnosis can lead to not having the correct equipment required for specific procedures. I'm not sure if many of you have stepped into an operating theatre before. Obviously, we don't have unlimited resources and equipment. We can only do a certain amount of procedures per day. If the patient is not being worked up and diagnosed correctly, that is part of emergency and trauma, but I also realise that it is part of the responsibility of the registrar and the consultant as well. But if we all do a good job, then we'll have the best outcome for the patient. If we do the pre-op workup properly, it'll be a less stressful environment and transition into theatre for the patient due to perioperative staff being a little bit more relaxed and with a comprehensive workup. As I said, the theatre is a pretty high stressful place when you're working there, and as a patient it is as well. But if a patient comes in and sees the staff happy, relaxed, as calm as they can be, then that really flows through to the patient. Most optimal outcome for the trauma patient, that's one of the major reasons that we need a pre-op workup done well. Emergency healthcare workers' involvement. I think I've tried to cover everyone in this room today. The paramedic. Some situations are difficult and it is purely situational dependent, I realise this, but the paramedic can gain crucial history from the patient and from family on the scene. Often when patients enter a hospital, patients become on high alert, for want of a better term, or are more stressed in an unfamiliar environment. Family members may not be present with the patient in the hospital, so a good opportunity for history taking is at the initial interaction. Paramedics also have an advantage of observing the environment from which the trauma was involved for diagnosis as well. ED clinicians. I've just made a note that they're able to undertake investigations that confirm diagnosis and confirm patient history. Physicians, nurses, nurse practitioners can stabilise the patient to ensure a better patient outcome post-operatively. With pathology and imaging, can establish any comorbidities and aid in the pre-planning for theatre. Some don'ts, please. I'm going to add please to this for perioperative preparation. These are things that my experience has taught me, and please feel free to ask questions because I probably can answer why I've written most of these. Don't suture children in ED. It's one of my pet peeves. It just causes trauma for future hospitalisation for kids. If you can avoid it, please do. It's much nicer if they go to theatre, are asleep and know nothing about it. When we're speaking of children, please try and use dissolving stitches. If you need a lesson on sutures, please come and speak to me later. Do not take ones that need to be removed. It is very traumatic. I work in an outpatient plastic surgery clinic. The amount of times I've had to take sutures out of children, and it is can be a nightmare. Animal bites. Probably different thinking on this, but I would often say never send someone home with antes if puncture marks are visible. Prepare for theatre washout. Again, as I said, I work in a plastics outpatient clinic, very busy. The amount of patients that I see return after going home on antibiotics with puncture marks from animals and they have become quite ill and septic is quite high. I know we all have time limits. We were talking about KPIs and everything else in all our lectures previously, and I know time is of the essence, and I know all the ED and emergency services try very hard to prioritise surgical patients, but comprehensive triage is essential. It would be best if we ensure all imaging and pathology that is done and is sent to theatre hopefully before the patient arrives, but at least with them, so that all the staff in theatre can have a look and try and manage and pre-plan for any of it. And minimise any treatment that may traumatise a patient going to theatre. Less stressful for patient to have treatment under anaesthetic. Again, I think this is probably more relevant to kids, but some adults don't like having stitches under local either. What happens is, particularly with children, it just causes trauma. That's about it. Perioperative is my love. Feel free to fire away. Happy to answer anything.
Does anyone have any questions for Fran?
Yes, drink time. Oh.
Yes, nice loud voice.
With your animal bites, I work in a hospital which we have a lot of animal bites. What's the usual time frame that they expect to operate after a dog or whatever bites?
The answer would be ASAP. I wouldn't leave it any more than 24 hours. I've seen animal bites after 24 hours and they've ended up in ICU.
Yeah, that's very interesting.
Yes, we do.
Sorry, I missed your first bit of it. Do you work in private or public?
I worked 15 years in a public hospital, big public hospital, and the last 9 in a private that has an ED department as well.
All right, I think, yeah, last one.
Do you notice the different types of care provided, public versus private, regarding timeframes? And because I'm assuming that all the cases would be very similar.
Yeah.
But do you notice a huge difference in
I have to be careful how I put this. With public hospitals, as you're probably aware, all public hospitals in Australia are teaching facilities. So generally, there are processes that we have to go through to get patients to theatre. The turnover is not as fast in the public system for multiple reasons, which I don't know if the government can fix. In private hospitals, most of the operations, surgeries are done by the consultants. So they try and get them in quick so that they can go home. So pretty much just, yeah, they try and get it done as soon as they can. Public is slower to get patients to theatre. There's also the other aspect of public. With public, you have a higher workload as well. You have a lot more patients entering a public hospital and a public emergency department. There's so many more people to look after. Theatres are often, lists in particular, theatre lists are interrupted with emergencies. After hours staff numbers and staffing, rostering is less. So it's only usually 1 or 2 theatres open for emergencies overnight. So that really slows down the work getting through as well. Private hospitals, they try to cater for surgeons and to get the work done. So I find in private hospitals, you're probably going to get through faster, just in general.
I think there's one at the back, nasty voice.
Do you ever have patients go direct from like the ambulance straight to theatre? So say they have their
Not so much in private, but in public I saw a lot of that, particularly, those big trauma patients they were talking about, and depending on their blood loss and what they needed, if they needed surgery straight away. I do work on the Mornington Peninsula in Victoria. I'm not sure if anyone knows that area very well. The public hospital I worked at was at Frankston, and it's a low socioeconomic area. We had a gunshot patient come straight through and they just diverted ED because they needed to get in there quick. We had multiple surgeons working on that patient.
Final question.
With the soluble suture, they're for the kids that take longer time to solve?
So there's 2 thoughts. Good question. This is my plastics nurse training coming through. With the non-dissolving sutures, you take them out after 7 days and it makes for better scarring. When I say don't put them in children, children's skin is able to regenerate and heal a lot better than elder skin, and so it can take up to 2 weeks for the dissolving stitches to leave the skin, but there's scar management techniques that you can go through with the family and the adults and their parents to reduce the scarring anyway. It's just less traumatic for the kids because they just fall out on their own.
All right, let's hear it one more time for Fran and for our presenters again.